everyone. My name is Liz Baker. I'm the Metabolic Fellow here at Cincinnati Children's, and I'll be talking about inborn errors of metabolism, hopefully in 20 minutes or less to help you guys study for boards. This is very jam-packed and has a lot of information. I'm hoping to put a lot of buzzwords that'll help you get the question right in boards, but also be able to help hopefully future in your careers as well. So let's get started. So inborn errors of metabolism are actually in three different categories to think about. So there's substrate intoxication. So those are disorders resulting in acute progressive accumulation of toxic compounds proximal to the metabolic block. So basically the enzyme starts working, you're not able to go downstream, and therefore you have a lot of toxic metabolites upstream of that enzyme block that can be detrimental to the body. The other category is energy deficiency. So those are where there's deficient energy production or utilization, so not able to create or utilize ATP appropriately in tissues and organ systems. And then last, there's disorders involving complex molecules. So those are diseases involving cellular organelles that disturb synthesis or catabolism of complex molecules. So those are in your lysosomes or your peroxisomes, things like that. So to go in a little bit more detail, so substrate intoxication, how I like to think about it is just like looking at this picture of a faucet. So you have water that's going downstream because the control knob is working appropriately, which is like our enzyme. However, if the enzyme isn't working right, you're stopping that water flow, and therefore you'll start getting compounds upstream, which are toxic. And has problems with the body overall. And we think about these in amino acid disorders, organic acidemias, urea cycle disorders, or sugar intolerances. So kind of the classic metabolic disorders that we think about. Next is energy deficiency. So I like to think about it as like if you're driving your car, your battery will recharge while you're driving it. However, if you have something wrong with the battery, it's not working appropriately, it's not recharging, and eventually the battery does die. And therefore you have problems with the car going. So same concept with these disorders. And we think about these with fatty acid oxidation disorders, glycogen storage disease, and mitochondrial disorders. And then last is complex molecules. So that's where you're not able to break down certain complex molecules so it stays inside the cell, just like you can see in this photo here, which is what you're normally supposed to do in the lysosome is break it down and then it gets out of the cell. However, an enzyme is not working appropriately, so you have these large molecules that are staying inside the lysosome. So the examples that we think of are lysosomal storage diseases as well as peroxisomal storage disorders. So now with that in mind, we'll go through each one of these categories and talk about different disorders within them. So for substrate intoxication, those include urea cycle defects, organic acidemias, amino acid disorders, and sugar intolerances. And how they present is both an acute encephalopathy or chronic encephalopathy. So acute encephalopathy are those with seizures, coma, lethargy, and severe hypotonia. And that's not present at birth. So they'll have a normal pregnancy. Their initial presentation after they're born is completely normal. But a few hours to days later, they'll present with these severe symptoms. And this is what we classically think of a metabolic disorder of a kid coming in sick into the emergency department. And you think about sepsis first, but you also need to think about inborn errors of metabolism. And the reason why it's not present at birth is because mom's enzyme is working appropriately and it's able to break down those substrates. Unlike when the baby's born and they're on their own, they have to be able to do it and it's not working appropriately. Chronic encephalopathy is slowly progressive as the metabolites start to build up. And usually this happens when the enzyme is working partially. So it's able to break down some things, but not break them all down like they're supposed to. So this is an algorithm to kind of help you delineate between organic acidemias, urea cycle defects, and fatty acid oxidation defects to hopefully help you get those questions right. So you have a kid that comes in to the emergency department encephalopathic. So most of us would get a blood gas, you would get as well as hopefully sometimes a pneumonia as well, especially if they're really young, only a couple hours or days old, since inborn errors of metabolism can present that way. So you have a kid come in with hyperammonemia, And you also have gotten your blood gas. So if they come in acidotic, then you need to consider organic acidemias. So you need to obtain at least a urine organic acid, but usually you also obtain acyl carnitine profiles as well as plasma amino acids. However, if they have a normal pH or they're alkalotic and you have your blood glucose, you can decide if they're hypoglycemic or hypoketotic. You think about fatty acid oxidation disorders. So you get an acyl carnitine profile, which looks at our fats. Or if they're normoglycemic, you think of urea cycle defects. And so then you need to obtain a plasma amino acid and urine orotic acid to look through that. So from your urea cycle defects, so looking specifically at those amino acids, if they have a lower absent citrulline, but a high urine orotic acid, you think of OTC deficiency. If they have a lower absent citrulline, but a low urine orotic acid, you think of CPS1 or NAGS deficiency. And I'll show you what this urea cycle defects look like in a pathway here in the next couple slides. If the citrulline is elevated as well as argininosuccinic acid, it's argininosuccinate lysase deficiency. If it doesn't have the arginosuccinic acid but elevated citrulline, it's citrullinemia. And if it's increased arginine, it's arginemia. So we're going to talk about urea cycle defects first. So this, excuse me, we'll have labs that have reveal a high ammonia and the respiratory alkalosis. So what we had talked about in that algorithm. And these are the disorders, which is just like I had showed you as well to kind of think of in or out. But the big things to notice is that both NAGS and OTC are rare, but they are severe. And then CPS1 is also very severe. OTC is X-linked, so that's the other big buzzword for it. The other ones are autosomal recessive. And the treatment for these disorders is that we want to go from catabolism or breaking down this protein to anabolism. So we'll give them glucose and lipids to hopefully shift that pathway over and not to use those amino acids. So this is looking at the urea cycle overall. So half of it happens in the mitochondria and the other half happens in the cytosol. But basically what these boxes are showing are those disorders. So these are the 3 at the beginning, and that's where they have that low citrulline because you're not able to make it. While these 3 down here have a high citrulline because you're not able to break it down. So sometimes it's helpful to kind of know the pathway to understand what the metabolites look like. But the big crux of the situation is citrulline high or low, and you can at least be able to kind of cut down on what those answers will be. Next is organic acids and those disorders. So those are defects in specific enzymes that process amino acids, specifically the branched chain amino acids. So valine, isoleucine, and leucine. And these labs will reveal metabolic acidosis with a normal chloride and hyperammonemia, but not as high as those in urea cycle defects. Those are the highest for ammonias. So those disorders are propionic acidemia. So those kids will come in and they'll have a really bad ketoacidosis, as well as having bone marrow suppression. So they'll be pancytopenic. So that's something to keep in mind. Methylmalonic acidemia, which is where they will also have hyperammonemia and ketoacidosis. Sometimes they'll have low platelets, and you can use B12 to help those kids out. There's isovaleric acidemia, and the kind of buzzword that you'll hear about is that they'll smell like sweaty feet, as well as encephalopathic. Then there's 3-methylcrotonol-CoA carboxylase deficiency, or 3-MCC. And it can be found in the newborn screen, and it's usually asymptomatic. So we actually test moms in those disorders because that might be the reason why the newborn screen is abnormal. And then there's multiple carboxylase deficiency, which has propyl-CoA carboxylase, 3-MCC, acetyl-CoA carboxylase, and pyruvate carboxylase that's not working appropriately. So they have a triad of encephalopathy, alopecia, and a skin rash overall. And the treatment of organic acidemias is, again, doing D10I fluids, lipids, and decreasing the protein intake. So again, you stay away from catabolism and go to anabolism. This is looking at those 3 branched chain amino acids and all the enzymes that goes through. And the ones that I circled is those enzymes that causes isovaleric acidemia, 3-MCC, propionic acidemia, and MMA. And then these arrows are just showing you the organic acids that we'll find when we do that screening. You don't need to know that, but that's just for your own knowledge. Next is amino acid disorders. So some of the more common ones is PKU, which is a phenylalanine hydroxylase deficiency. So you're not able to have phenylalanine to be broken down appropriately. They all have a specific order of mousy odor. They also will have fair hair, fair skinned, and severe intellectual disability if they're not treated, which is a phenylalanine restricted diet. The phenylalanine level will be elevated and the tyrosine level will be low. And then another thing to note is a maternal PKU. So if mom has PKU and they become pregnant, then the infants, if they're not treated appropriately, will have growth deficiency, microcephaly, intellectual disability, and congenital heart disease. So it's important for the moms to still be on that special diet to keep their phenylalanine levels in the appropriate range. Next is tyrosinemia, so abnormal tyrosine metabolism. So most commonly on the newborn screen, it's seen in premature infants, which is transient tyrosinemia of the newborn. It's just that their liver isn't functioning appropriately because it's just immature. And so we just watch over time, but there's no defect overall from an inborn error perspective. And then there's tyrosinemia type 1, which is hepatorenal tyrosinemia, which you actually don't get elevated tyrosine, but you do get increased succinylacetone, which is a downstream effect. And that's what we look at in newborn screens for. And these kids, if they're not treated, will have failure to thrive, hepatomegaly, as well as hepatoadenomas that can come to hepatoblastomas and liver failure. And so then we treat those with nitidazone or NTBC. Some other amino acid disorders is maple syrup urine disease or MSUD. So those are branched chain keto acid dehydrogenase complex deficiency. So that's the first step in the branched chain amino acids being broken down appropriately. So your valine, isoleucine, and leucine are elevated. They have the specific smell of maple syrup urine or maple syrup in their urine and cerumen, just like the name says. And they show up and present as well as birth. Then they'll have seizures, opsistonia, which is basically rigidity overall. And then rigidity at day 3 to 5, and then death from cerebral edema. Another disorder is glutaric acidemia type 1, which is gluteryl-CoA dehydrogenase deficiency. And lysine is the amino acid that's the offending agent, but it's not elevated when we look at it on a plasma amino acids. The urine organic acids are abnormal. And then what you'll see on test questions is that these are the kids that show up with subdural hemorrhages or retinal hemorrhages that can be mistaken for non-accidental trauma. And then they'll also get strokes if they have a metabolic crisis in the metabolic or in the basal ganglia. So then they'll have problems with movement disorders. And then the last amino acid disorder I'm going to talk about is homocystinuria. And we know that those kids usually have a marfanoid habitus, so they are long and lanky. So it's good to know the difference between homocystinuria and Marfan syndrome, which is what this table shows. So homocystinuria is autosomal recessive in the CBS gene, while Marfan's is FBN1, which is autosomal dominant. And then basically everything is the opposite. So homocystinuria has intellectual disability, Marfan syndrome does not. Homocystinuria has a downward dislocation of ectopia lentis that you'll see on boards, while Marfan syndrome will have an upward dislocation. That's not necessarily seen in real life, but they do like to test that on boards. Then there's limited joint mobility in homocystinuria versus hyperflexibility in Marfan. Homocystinuria has a normal aorta, while Marfan's has aortic dilation. Homocystinuria has clots, while Marfan's doesn't. Homocystinuria, you look at the plasma amino acids, specifically plasma homocysteine and methionine levels, while Marfan's is diagnosed by specific Gens criteria. And then treatment for homocystinuria is vitamin B6, while Marfan's will do beta blockers and sometimes will need surgery for their aortic dilation. Next is sugar intolerance. So that is galactosemia is the classic example. And that's due to a GALT enzyme deficiency. And how these kids will present is that they'll have severe jaundice, hepatosplenomegaly, they'll have cataracts congenitally, intellectual disability, and then E. coli sepsis, especially in the neonatal age. So if you see a kid who has E. coli sepsis on your board's question, then I would think about galactosemia. The diagnosis is usually now by newborn screen, but they used to do reducing substances when drinking breast milk, cow's milk, or formula. And that would be because the galactosemia or the galactose wasn't being processed appropriately. Then there's hereditary fructose intolerance, which is an aldolase B deficiency. So their symptoms are similar to galactosemia, but usually later on in life. And that's when fructose is introduced. So they're starting to have fruit or sugar more in their diet. So they'll have jaundice, hepatomegaly, vomiting, seizures, and irritability around that 6-month age. And then sugar ingestion actually causes hypoglycemia, which you obviously don't think will happen under normal circumstances. Next is energy deficiency. So the 3 disorders we'll talk about is fatty acid oxidation disorders, glycogen storage diseases, and then mitochondrial disorders, specifically from a mitogenome perspective. So fatty acid oxidation disorders is due to beta oxidation that occurs in the mitochondria. So what happens is that they're taking off 2 carbon units each time that goes through that cycle, which then makes acetyl-CoA, which then can go into the Krebs cycle. And that's the main energy for heart and skeletal muscles during fasting. So the labs will reveal hyperammonemia, again, not as high as urea cycle defects, hypoketotic hypoglycemia, and then elevated CPK. The disorders we think about is MCAD. That's the most common. And usually the infant has fasting-induced lethargy and hypoglycemia. And that's one of the things that we think cause SIDS before we put it on the newborn screen. There's LCHAD deficiency, which has the same presentation as MCAD plus retinopathy, cardiomyopathy, and rhabdo. Carrier mothers can also have fatty liver, pregnancy, or HELP syndrome. So that could be something you could see in boards and in real life. And then you have VLCAD deficiency. So same as MCAD plus they have arrhythmias, cardiomyopathy, and rhabdo. So the treatment for this, again, is trying to go into an anabolism. So you give them a lot of glucose, but you obviously can't give them lipids if they can't break down fats appropriately. Next is glycogen storage diseases. So I'm going to go over a couple of them, not all of them, because that would take another lecture. So there's type 1 GSD or von Gierken's disease. So type 1A is glucose 6-phosphatase deficiency. And then type 1B is a defect of transporting that glucose 6-phosphate over the cell membrane. So the presentation is usually around 3 to 4 months of age with failure to thrive, doll-like faces, hepatomegaly, enlarged kidneys, and hypoglycemic seizures. And your labs will show hypoglycemia, lactic acidosis, hyperlipidemia, elevated ketones, and neutropenia in type 1B. So type 1B only has a neutropenia, not 1A. And the treatment is to prevent hypoglycemia. So usually these kids have to have tube feeds because they can't go more than a couple hours, maybe an hour or 2 without feeds, and then also cornstarch. And then you need to give GCSF and type 1B for their neutropenia. Type 2 is Pompe disease, which is unique because it's both a glycogen storage disease and a lysosomal storage disease. And so basically what happens is the lysosomal acid alpha-1 glucosidase breaks down glycogen in the lysosome. And their presentation is both infantile and juvenile or late onset. So the infantile is the most severe with hypotonia, like you see in the picture below, cardiomegaly, cardiomyopathy, and failure to thrive. And usually these patients will pass away within a year if they're not treated. And then juvenile late onset is slowly progressive weakness without the cardiomyopathy. And there's major variations among what that looks like. The labs will include CPK, AST, and LDH that are elevated, and the treatment is enzyme replacement therapy, which can be very beneficial, which is why it is on the newborn screen in a lot of states. And then the last glycogen storage disease I'll talk about is type 5 or McArdle disease, which is an adult onset disorder. They have exercise intolerance and muscle cramps that can lead to rhabdo. The labs will show elevated CPK at rest, an increase with exercise, as well as an increase in ammonia, but not lactate, which is abnormal compared to what we see in other patients that don't have this disorder. Another one of the energy deficient is mitochondrial disorders from mitogenome. So these are these are disorders that are passed through the mitogenome. So this is maternally inherited, but there are hundreds more that are recessive or nuclear. So that are through the nuclear genome. I'm not going to talk about those. So the disorders that are Mitochondrial DNA, so maternally inherited, includes Kirin-Sayer or chronic progressive external ophthalmoplegia. So these kids will show up with ptosis and ophthalmoplegia, but the big thing to know about is the heart block. So they need to be on Holter monitor because it can go into type 1 heart block. There's myoclonic epilepsy and ragged red fiber disease, which has exactly what the name says, epilepsy, cerebellar ataxia, and ragged red fiber myopathy. Then there's mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes, or MELOS. Again, the name tells you exactly what it has. So they have stroke-like episodes that can be associated with migraines and seizures, but in the non-watershed areas. They can have cerebellar ataxia that occurs way before the strokes happen. Also have cardiomyopathy, diabetes, and deafness. So you give arginine during those stroke-like episodes. And then you have Lee syndrome, which is T2 MRI reveals basal ganglia, cerebellum, and brainstem hyperintensities. And then they have mental and movement disorders, respiratory dysfunction, ataxia, cardiomyopathy, and muscle weakness. And then last is complex molecules, so lysosomal storage disorders and proximal storage disorders. So lysosomal storage disorders, so there's Hurler syndrome, which is presentation has coarse facial features, large tongue, corneal clouding, umbilical hernias, macrocephaly, deafness, and ID. And so then you give them enzyme replacement and bone marrow transplant can happen. Then type 2 is Hunter syndrome. So the big thing with that one compared to Hurler's is it's X-linked, but it does not have corneal clouding. And the way to remember that is that a Hunter needs to be able to see, so they won't have any corneal clouding. And the enzyme replacement therapy is treatment. Sanfilippo, or type 3, is diagnosed later at 4 to 5 years of life with severe CNS involvement with not much somatic disease. And aggression is usually a very difficult thing to control. And they usually have problems with swallowing later in disease. And then there's Morquio syndrome, or type 4, which has a skeletal dysplasia, odontoid dysplasia, which can be life-threatening, but they also have normal intelligence. Some other lysosomal storage disease is Gaucher, which is there's type 1, which has no CNS involvement, but visceral involvement. So they have splenomegaly, bone pain, and growth retardation, and you give them enzyme replacement. Splenectomy is controversial because it usually makes the bone disease worse. Type 2 has CNS disease, which that is usually will cause difficulty swallowing and oxytonic posturing, which you see in the picture here. And the treatment is for ERT for that as well, but it only works on the visceral symptoms, but not the CNS. Fabry disease, it's X-linked, and it comes up with hypohidrosis, which has difficulty with sweating, angiokeratomas, which are purple spots, corneal opacities, pain, fatigue, renal disease, and cardiomyopathy, and the treatment is ERT. And then last is peroxisomal disorders. So there's Zellweger syndrome. So they are dysmorphic, like you see in these pictures here with hypertelorism. They have large anterior fontanelles, cataracts, retinopathy, and hearing and vision loss. And then you have X-linked adrenal leukodystrophy, which is adrenal insufficiency and leukodystrophy. Sometimes they have one or the other of those two symptoms, and you're unable to tell that at birth, and they have serial monitoring because it's on the newborn screen in most states. So some conclusions or high-yield facts is that if you have any question that states ethnic or genetic background, or say that they're consanguineous or are first cousins, then consider inborn errors in metabolism or some sort of genetic disorder. Most of these disorders are autosomal recessive, but OTC, Hunter syndrome, X-linked adrenal leukodystrophy, and Fabry are X-linked. Mitochondrial are maternally inherited, and then I didn't talk about this disorder, but porphyria or acute intermittent porphyria specifically is a rare example of dominant disorders. And then things to use to study, this Peds in Review has a great article called Inborn Errors in Metabolism, Becoming Ready for Rare. And then MedStudy has great questions, and also the book has a lot of great examples of these as well. Thanks, guys. Appreciate it.